I was invited to come and speak about the potential for immunotherapies in the treatment of gynecological tumors. The reason for this is that when we see our patients in clinic, one of the most common questions from our patients is, "Doctor, can I have an immunotherapy?" The thing is, gynae cancers aren't melanoma, they aren't lung cancer. And for now, the data we have about the potential for immunotherapies in gynae tumors is still very early data. So I think we need to stay level-headed, and that's why my talk was hyper hope about immunotherapies in gynae cancer. And if we are to be honest, response rates today in early phase 1 trials are of the order of 10%. We've had updates at ASCO a couple of weeks ago with a larger number of patients. Response rates are 8% in ovarian cancer, 13% in cervical cancer. So I think we need to step back and try to learn about these disappointing results and try to understand more about why. I think we can only hypothesize maybe we should be treating these patients earlier when they're not immune exhausted, when their volume of disease is lower, big bulky disease is unlikely to respond. And then we're going to have to focus, can we find biomarkers? And I think for now, at least we have one very encouraging biomarker, and I think for us our best candidate for immune therapies are MSI endometrial cancer patients. Now this is one example of an alteration that really predicts the response to single-agent immunotherapies. And in the US, the FDA has given approval to immunotherapies, specifically Pembrolizumab, for MSI tumors. And it's the first time we have a biomarker associated with a treatment that's tumor agnostic. And that's a real step forward, and I think we need to be testing our patients for MSI and trying to get our endometrial cancer patients onto clinical trials. Beyond that, I think we're going to have to learn about which combinations and whether we should be thinking beyond PD-1, PD-L1 into more novel approaches, personalized immune therapies using the own patient's T cells, whether we should be doing injections into the tumor, and definitely using these treatments earlier on in the disease when there's a chance we might be able to control using the host immune system. So we have a lot to learn.